Hello all, today we're talking about chapter 20, continuing that conversation. We'll finish it up here today. Clients with cardiac and respiratory conditions, looking primarily at COPD and asthma. COPD stands for chronic obstructive pulmonary disease. It is a progressive and chronic lung disease characterized by persistent respiratory symptoms and airflow limitation. The primary cause of COPD is long-term exposure to irritating gases or particles such as cigarette smoke, air pollution, or occupational hazards, primarily caused by smoking, but also by respiratory infections and exposures to environmental air pollutants. COPD is the third leading cause of death in the United States. COPD symptoms typically develop slowly and worsen over time. Common symptoms include chronic cough, shortness of breath or dyspnea, especially during physical activity, wheezing, chest tightness, increased production of mucus or sputum, frequent respiratory infections, fatigue, and unintended weight loss. Exercise plays a crucial role in the management of COPD. While COPD can make physical activity challenging, regular exercise can help improve lung function, increase exercise tolerance, enhance muscle strength, and improve overall quality of life for individuals with COPD. Here are some important considerations and benefits regarding exercise for people with COPD. It's important to consult with a healthcare professional before starting an exercise program to ensure it is safe and appropriate for your client's condition. Individuals with COPD may have certain limitations, and exercise should be tailored to their abilities. You want to start slowly and gradually increase intensity, duration, and frequency over time. Pulmonary rehabilitation programs, typically offered in a supervised setting, provide a comprehensive approach to exercise education and support for individuals with COPD. They can help optimize exercise programs and provide additional resources for managing COPD. Asthma and exercise-induced bronchoconstriction, or EIB, are two conditions related to the respiratory system. Here's an overview of how each is condition and how they are related. Asthma is a chronic inflammatory disease of the airways characterized by recurrent episodes of wheezing, shortness of breath, chest tightness, and coughing. It can be triggered by various factors such as allergens, respiratory infections, irritants, and exercise. In asthma, the airways become inflamed and narrowed, leading to difficulty in breathing. Exercise-induced bronchoconstriction, or EIB, is exercise-induced asthma, refers to the narrowing of the airways that occurs during or after physical activity. EIB is a common condition among individuals with asthma, but it can also affect people without a history of asthma. The exact cause of EIB is not fully understood, but it is believed to be related to the cooling and drying of the airways during exercise, which triggers the release of inflammatory substances and causes bronchoconstriction. EIB is considered a subtype or manifestation of asthma. Many individuals with asthma experience symptoms of EIB, particularly during or after exercise. However, not all individuals with EIB have a diagnosis of asthma. The symptoms and triggers of EIB are similar to those of asthma, but they are specifically related to physical activity. Medications can improve symptoms, reduce the frequency and severity of exacerbations, and improve lung functions. Here are some important pharmacological considerations in asthma management. Controller medications. These are inhaled corticosteroids, or ICS. These anti-inflammatory medications are the most effective long-term treatment for asthma. They help reduce airway inflammation and prevent symptoms. Examples include fluticasone, budesonide, and beclomethasone. Long-acting beta agonists, or LABAs, are bronchodilators that help relax the airway muscles and improve breathing. They are often used in combination with ICS to provide better asthma control. Examples include salmeterol or formoterol. Combination inhalers contain both ICS and LABA are available. They provide the benefits of both medications in a single inhaler, simplifying the treatment. Examples include fluticasone, salmeterol, and budesonide and formoterol. These medications block the effects of leukotrienes, which are inflammatory substances involved in asthma. They can be used as an alternative or additional therapy to ICS. Additional medications such as long-acting anticholinergics, mast cell stabilizers such as cromolyn sodium, and immunomodulators may be prescribed in specific cases. There are also quick relief medications or rescue medications. These are short-acting beta agonists or SABAs. These bronchodilators provide rapid relief of asthma symptoms by relaxing the airway muscles during an acute asthma episode. Examples include albuterol. Systemic corticosteroids are oral or intravenous corticosteroids, which may be prescribed for short periods during asthma exacerbations to reduce airway inflammation and improve symptoms. Proper inhaler technique is crucial to ensure effective drug delivery to the lungs. Patients should be educated on the correct usage of their inhaler devices, such as metered dose inhalers, or MDIs, or dry powder inhalers, or DPIs. Spacer devices can also be used to enhance drug deposition in the airways. The modified Borg scale, also known as Borg dyspnea scale or Borg rating of perceived exertion scale, RPE, is commonly used to assess the level of dyspnea or shortness of breath experienced by individuals during physical activity. It is a subjective scale that allows individuals to rate their perception of breathlessness. The scale ranges from 0 to 10, which corresponds descriptions are as follows. 0 is no breathlessness at all, whereas 0.5 is very, very slight breathlessness. 1 signifies very light breathlessness. 2, slight breathlessness. 3 is moderate. 4 is somewhat severe breathlessness, while 5 is severe. 6, very severe. 7, very, very severe. And 8, almost maximal breathlessness, with 9 being maximum and 10 is complete breathlessness. When using the Borg dyspnea scale, individuals are asked to select the number that best represents their level of breathlessness at a given moment during exercise or any other activity. This subjective assessment helps healthcare providers, exercise specialists, or researchers understand and monitor the perceived level of dyspnea experienced by the individual. It's important to note that the Borg dyspnea scale is just one tool among several used to assess dyspnea, and individual interpretations may vary. You can also use an oxygen saturation tool to help in determining how much oxygen saturation that the individual might have. That gives you a good indication as to how short of breath they are as well. It is recommended to consult with their healthcare professionals or specialists for accurate interpretation and to incorporate other objective measures and clinical assessments for a comprehensive evaluation of dyspnea. Asthma Action Plan is a personalized written document that outlines specific instructions and steps to manage asthma symptoms, prevent exacerbations, and provide guidance for appropriate medication use. It is typically developed in collaboration with a healthcare professional, such as a doctor or asthma educator, and tailored to the individual's needs. Here are the key components typically included in an asthma action plan. First, personal information, their name, contact, and date of birth of the person with asthma. An emergency contact information, including the names and phone numbers of emergency contacts and healthcare providers. The asthma severity classification. This is based on the individual's symptoms, lung function tests, and medication usage. Their asthma severity is determined and categorized as intermittent, mild persistent, moderate persistent, or severe persistent. This classification helps guide treatment decisions and medication choices. The action plan includes color-coded zones, usually green, yellow, and red, what you see here, and based on symptom severity and lung function measurements. Each zone represents different levels of symptoms and recommended actions. The green zone represents good control and indicates no or minimal symptoms. It outlines the individual's daily medication regimen, including preventer medications, as well as any specific instructions for maintaining asthma control. The yellow zone indicates a cautionary or worsening phase with increased symptoms. It provides instructions for adjusting medication doses or adding additional medications to regain control. It may also include guidelines for monitoring peak flow readings or symptoms and when to seek medical advice. The red zone represents a severe exacerbation or emergency situation requiring immediate medical attention. It includes instructions for using rescue medications, contacting healthcare providers or emergency services, and steps to take until medical help arrives. When it comes to exercise and asthma, it's essential for individuals with asthma and exercise-induced bronchoconstriction, or EIB, to stay physically active while managing their symptoms. Here's some exercise guidelines for individuals with asthma and exercise-induced asthma. First, consult with a healthcare professional. Before starting or modifying an exercise routine, it's important to consult with a healthcare professional, such as a doctor or asthma specialist. They can assess the client's asthma control, provide personalized recommendations, and prescribe appropriate medications if necessary. Engage in a thorough warm-up before exercise. This will help prepare the airways for physical activity and may reduce the risk of asthma symptoms. A warm-up can include light aerobic exercises and stretching. You want to choose suitable activities. Select activities that are less likely to trigger asthma symptoms. Generally, activities that involve short, intermittent bursts of exertion, such as walking, swimming, cycling, or yoga, tend to be well tolerated by individuals with asthma. Avoid exercises in cold, dry environments as they may exacerbate symptoms. You should recommend that your client be properly instructed to perform a minimum of 10 to 15 minute variable intensity aerobic warm-ups. And for untrained asthma individuals, exercises using lower resistance, such as an RPE of 11 to 13 and higher repetitions of 2 to 4 sets of 10 to 15 reps per set, focusing on major muscle groups with extended rest intervals, 3 to 4 minutes per set. General fit recommendations pertaining to aerobic resistance and flexibility training can be modified to each individual's capabilities and capacities. And in working with clients who have cardiovascular respiratory conditions, it poses unique challenges. It is common for these populations to present with more than one of these diseases or conditions. Your job is to have the information on the client's clinical status, including their health history, current symptoms, medications, and any contraindications before implementing an exercise program. Begin with a prescription for the condition of highest risk will help you prescribe exercise appropriately. And that is all that I have for you today. I look forward to talking with you again. Have a great day.